we're going to move quickly to our next speaker. Eric Avesian is a medical resident in cardiology at the National Medical Research Center in the Ministry of Healthcare in the Russian Federation. Welcome, Eric.
Thank you very much for the invitation to this very important conference. I had to say that in our everyday practice as cardiac intensive care unit, we had only been using renal replacement therapy from a long list of extracorporeal hemoperfusion techniques. But to say for true bacterial infections and infectious complications, so in our patients were not so rare, and sepsis and septic shock, we had them from time to time. And now it's clear that this method, hemopurification with, for example, Jafron device, can be very useful in our usual work. But during COVID-19 pandemic, guided by our colleagues, we managed to perform fairly large number of procedures for us for 2 months of work, and we hope that in the future we will follow this path. The first case in Russia, the first positive test was made in January, and now we have almost 600,000 patients here in Russia. 2 months work with COVID-19 patients, 82 patients admitted in our intensive care unit, the third of them with severe cardiac comorbidities, and we performed we treated 8 patients with this extracorporeal hemoperfusion techniques by means of cytokine hemoabsorption and selective plasma filtration. This is our local definition of COVID-associated cytokine release syndrome. It's based on the data available in the world and our own practice. As soon as cytokine release syndrome is diagnosed and initial treatment started, the severity of CRS is being assessed. For severe and patients with multi-organ dysfunction syndrome, we decide to provide this hemopurification techniques. We use a Jafron device for hemaperfusion and plasma filter Evacuate 2C. We believe that combination of these two methods in one procedure or one after another can bring a lot of benefits because of, first of all, more intensive purification during one procedure or one after another, as I said, or wider spectrum of removed molecules and the toxin removal, better removal of smaller molecules, for example, for the patients with kidney and liver failure. And we also think that it can be a base for more prolonged time of effective cartridge work. So as I said, the inclusion criteria for us was severe COVID-19 associated CRS when interleukin antagonists are ineffective or unavailable or contraindicated. We use that even without acute kidney injury and without the need of renal replacement therapy or ECMO. The parameters that we used for the assessment of the effects of these procedures you can see on this slide. As I said, we treated 8 patients. In all patients, we have seen decreased cytokine levels after the procedure and during the follow-up. Positive clinical effect we have seen in 4 patients out of 8, and we have not seen any procedure-related complications. Here are basic characteristics of our patients. We separated them into 2 groups on the basis of the outcomes. 4 of our patients were successfully discharged from the hospital. 4 of them died during the ICU stay. As you can see in the survivor group, survivors were younger and they had fewer comorbidities. In most of our patients, we used interleukin antagonists. Respiratory support was as following. 3 of our patients were on invasive mechanical ventilation, but we also had patients on non-invasive ventilation and even on high-flow oxygenotherapy, high-flow ventilation. Vasopressors were used in 1 patient from each group. They were in septic shock, as you can see. Acute kidney injury and bacterial co-infections were not so rare. Here you can also see the procedures that we performed in our patients and the number of the procedures made. We are familiar with the concept, with the recommendation that about the regimen of the procedure of the hemoperfusion, 2+1+1, but because of some reasons, because of the shortage of devices and shortage of specialists in this from this area, we decided to be guided by the clinical and laboratory parameters when we were deciding the procedure to be done. And we're also trying to figure out the time frame from the beginning of CRS, COVID-associated CRS, to the initial initiation of extracorporeal technique. And of course, it's a retrospective analysis of limited patients, but we figured out that the time frame was shorter in survivors. And we also want to talk a little bit more about one of our patients. He is 50 years old, a male, and we want to point out to take a closer look to that when procedure is done is made early, it can have it can figure out more effective. The disease started as usual with a high fever and dry cough. On the 7th day of the disease, shortness of breath, tachypnea, the features of respiratory distress appeared, and then he was admitted to our ICU with a higher fever and with severe dyspnea. And we think that this rapid sudden deterioration in respiratory function can be interpreted as the beginning of CRS. Here is the CT scan. You can see a large areas of ground glass opacities and consolidations. On admission, his oxygen saturation was as low as 77% on ambient air. Tachypnea was observed with respiratory rate of 30 breaths per minute. ABG showed decompensated respiratory alkalosis. On a venous blood sample, you can see neutrophilic leukocytosis with absolute lymphocytopenia. CRP and procalcitonin were also high. The initial treatment was started with respiratory support by means of high flow ventilation with the following parameters, and medications were started as usual with antimicrobials because of the elevated RCT. Here you can see how things unfolded during his stay in our ICU department. On the 3rd day of stay in our department, basing on the very high level of ferritin, very high level of CRP, interleukin-6, increasing white blood cell count, and sustained fever, we decided to initiate hemopurification procedures. You can also see that he was, by that time, transferred to non-invasive ventilation. That means that his respiratory function deteriorated. So we started with selective plasma filtration because of the rising AST and creatinine levels, because of the multi-organ dysfunction, the early stages of multi-organ dysfunction syndrome. After that, the procedure lasted 5 hours. After that, we took a blood sample, and we had seen a decrease in pro-inflammatory markers and a little bit decrease in fever. After that, in a very short period of time, between the procedures, we started hemoperfusion by means of cytokine absorption with the use of Gefron HA330. Procedure lasted 4 hours, and after that, after 1 or 2 hours before the procedure, we took the blood sample, and interleukin was, as you can see, 65, and CRP was going down, and AST creatinine was also started to decrease, and fever has gone. He was transferred to nasal cannula. After his stay in our hospital, on the 3rd day from the last procedure, he was transferred from ICU to the ward department, and on the 7th day he was weaned off from any respiratory support. On the 14th day he was discharged, and you can see the dynamics of the parameters. We believe that in this patient and in a couple of another patients who were suffering from CRS in the very beginning, the use of combined therapy, combined approach, resulted in better outcome and allowed us to avoid advanced multi-organ dysfunction and intubation with the transfer to invasive ventilation. So in conclusion, I'd like to point out the next statements. Hemoperfusion is an effective treatment modality, and it should be performed in patients with severe COVID-19, of course, and CRS. And in our opinion, combination of cytokine hemoperfusion with selective plasma infiltration